Now, this is the next speaker, Mokhtar, Mohsen Mokhtar. Her talk, update, treatment in advanced and recurrent cervical cancer. Please.
Thank you very much. It's an honor to be here, and I'm very pleased with this conference, and thank you for allowing me to be part of it. So my task is to follow up on everyone that has been talking about cervical cancer the whole day, and I'm going to give the updates. Luai made it a bit easier because he gave some of them out. Updates for the management of both advanced and recurrent metastatic cancer. These are my disclaimers. The interlace that Luai showed on in terms of locally advanced cases, that was, as Luai said, in the last ESMO. These are patients with stage 1B up to 4A, induction followed by concurrent chemoradiotherapy. But again, if you look at this group of patients, again, in specifically, they were stage 2B and 3B. These were the majority of the cases. And again, you can see that the majority, or nearly half of them, were node positive, especially if we're talking about the patients who had induction followed by concurrent chemoradiotherapy. And I think that is also a caveat in this trial. One of the things that you can see is that both progression-free survival and overall survival, you do have a benefit in terms of the hazard ratios that was statistically significant. And especially if you look at the 5-year survival, whether progression-free survival or overall survival, you are seeing around a 10% benefit from this. And as I said, immunotherapy is coming on to this. Again, in the SGO this year, this was a presentation of a phase 1 trial with atezolizumab, whether in the neoadjuvant or concurrent plus chemoradiotherapy. If we look at this group of patients, again, stages 2B up to 4. And if we look at the majority of these cases, again, stage 2B, 3B were the majority of these cases. And if we look at the PD-L1 scoring of these patients, the majority of the patients had a PD-L1 score, whether it was tumor or immune, more than 1% of the positivity. If you look at the response, the neoadjuvant versus the concurrent progression-free survival, as well as the pathological response, obviously, with the neoadjuvant, it is much better. And that's why if you're going to use immunotherapy for your patients, the earlier you use it, the better you're going to get in terms of results because of the resistance mechanism that happens down the line. Then we had chemoradiotherapy with Pembro, similar trial to what Luai had shown, but this was in the SGO. This was the phase 2 trial of this. Concurrent chemoradiotherapy followed by Pembro, or starting off with the Pembro plus chemotherapy with the concurrent chemoradiotherapy. And what we can see again in this group of patients, the majority were stage 2 and majority had positive lymph nodes. And if you look at the disease-free survival and overall survival, you are seeing a difference and a trend in favor of the concurrent or the Pembro during the concurrent chemoradiotherapy. Now, the phase 3 trial, the keynote 18 that Luai just again showed, this was over 1,000 patients. Remember, stage 1B, 2B, as well as node positive or that had node positivity, stages 3 and 4A were included. Pembro plus concurrent chemoradiotherapy versus concurrent chemoradiotherapy with Pembro for 15 months. And again, probably that would be the caveat for many centers in many countries because of the cost of the Pembro for 15 months. If we look at these patients' PD-L1 status, more than 1 was in 93% of the patients. And if you look at the majority of patients, they were well balanced between stages 1B, 2, 3, and 4A. If we look at the overall response rate, you are getting a slightly higher response rate. But if you look at the duration of the response, you are seeing a difference of around 4 months in that. But if you look at the progression-free survival, hazard ratio 0.7. So that's 30% benefit. And again, at 2 years, you are gaining around 10% benefit, 67% versus 57% for the patients on the Pembro. But remember, these patients were on Pembro for 15 months. So they had just stopped the Pembro for around 9 months. Probably all subgroups of patients did benefit from this treatment, whether it was the stages 1B, 2B. Obviously, stage 3 and 4 will benefit more. And if we look at the overall survival for these patients, what we can see is that the hazard ratio is 0.73. I wouldn't say that this till today is an overall survival definite benefit. I think we're going to need to wait longer for this. One of the things that you can see, and I think this is very important for our patients, is patients leading to discontinuation of any treatment. We can see with the addition of immunotherapy, we didn't have an increase in stopping or discontinuation of therapy. If we shift gears to metastatic and recurrent carcinoma, immunotherapy is probably the major player in all of this. We have the BEAT-CC trial. This was again presented in the last ESMO. Atezo, Bev, paclitaxel with platinum, whether cis or carbo, versus the same regimen without the atezolizumab or Tecentriq, 410 patients properly randomized to this. And what you can see in this trial, and I think this is one of the major considerations, you're looking at progression-free survival and overall survival for these patients, and this was given until disease progression. What we can see in this well-balanced trial, the majority of the patients had squamous, 23% had adenocarcinoma, which I don't think, again, would probably make a difference. Overall response rate, you are seeing higher response rate, and if you look at the duration of response, you are seeing an increase of around 6 months plus for the atezolizumab arm. The progression-free survival, 62, PFS 13 versus 10, hazard ratio 0.62, overall survival 0.68, and if we look at PFS in all subgroups, similar in benefit of all subgroups of patients, regardless of histology, regardless of prior chemoradiotherapy, and regardless of the platinum-based therapy. Safety summary, well balanced. If we look at the Keynote 826 trial, this is the other trial with immunotherapy, 617 patients, Pembro plus or minus with Bev, and platinum-based therapy. We look at all comers and look at the characteristics of all of these. The final overall response rate, you can see that the duration of response, whether the patient had a CPS 1 or 10, was similar. So what I think is there for our patients, look and check for the combined positive score. You probably need a combined positive score, and if you have a higher, you will get more benefit, but more than one is enough. If we look at the PFS, hazard ratio 0.6s, 0.58 in the combined positive score, more than 1 and more than 10. 12-month survival, 24-month survival is similar, and that's why I say if you have a patient with a CPS more than 1, the addition of immunotherapy, whether it's the Bev or the Atezo, is of benefit for these patients. Safety summary, nothing to look out for. If you've been using immunotherapy, then again, these patients, you probably will have a good practice with the management of safety, and as we can see, it's not really much in terms of addition of toxicity, except for the financial. Now, the question of bevacizumab, and I think this is really important. Do I need Bev, yes or no? This was data from the final overall survival that was presented in the in SGO this year, the Keynote 826, whether the addition of Bev specifically would benefit these patients, because 37% of the patients had not received bevacizumab from the Keynote 826 trial. What we see is whether in the CPS population or in the old comers, the addition of Bev increased the overall response rate with the Bev in the all comers and in the CPS. The duration of response was increased. If we look at the overall survival with Bev or without Bev, we can see that, I just want you to focus on the 22 months there and the 12 months. So the addition of Bev is definitely of importance in all comers and even in the CPS scoring, 23 months versus 12 months. So try not to omit the bevacizumab in that 4-drug regimen. Lastly, the last comer is the tumor factor monoclonal antibody, trastuzumab vedotin. This is after recurrence of several lines of therapy versus chemotherapy of choice, looking at overall survival, progression-free survival, and overall response rate. If we look at the characteristics of these patients, probably well balanced. The majority had received bevacizumab, and in this trial, a good 25% of the patients had received an anti-PD-L1 or PD-1 therapy. Most of the patients had extra pelvic metastatic disease in around 90% of the patients. This is a waterfall plot that you do want to see. The overall response rate, you can see going up from 5 with your classic or standard chemotherapy versus 18. Duration of response, unfortunately, has not been met, but you can see from the waterfall plot that these patients do have some benefit, and the progression-free survival, your hazard ratio is 0.67 in terms of PFS. Overall survival, which is a primary, another primary endpoint, we can see that the hazard ratio is 0.7 with 48 versus 35.3 in terms of overall survival at 12 months for these patients. Now, if you want to look closer, this is at a more closer look, whether the patients had received prior Bev or not. I think that's the only matter of that. But you can argue that the number of patients that had not received Bev were obviously a lot less than those that had received. So probably we could not fully withdraw that conclusion. You are going to see more adverse events, and this is for the oncologists on the room. We are going to have to get more friendly with our ophthalmologists, because any new therapies that are coming on in oncology, whether they're TKIs or these monoclonal antibodies, are doing some ocular or causing some ocular problems. So please get friends with your ophthalmologist at the hospital. As Loai said, the NCCN guidelines have not yet incorporated immunotherapy in the locally advanced. You're still seeing the platinum-based therapy, concurrent chemoradiotherapy. But what we can see is that in first-line therapy for the metastatic setting, we are seeing more and more of addition of immunotherapy for these patients. And till today, I would still offer these patients immunotherapy plus bevacizumab rather than immunotherapy, chemotherapy on their own. And thank you very much for your attention.